Coming on to the last session of this symposium, we have with us Dr. Rakesh Kumar Sharma. He is Professor of Medicine and Cardiology, University of Arkansas Medical Sciences. He is board certified for cardiovascular medicine, interventional cardiology and cardiovascular CT. Dr. Sharma, please.
Thank you much. Well, I want to start with thank you Dr. H.K. Chopra, Dr. Naveen, and all the organizings. This is a wonderful meeting. What we're going to talk about is something very simple. Some you practice every day, and hopefully you will take some message home. And first half of the talk is, this is acute MI symposium. So first half of the talk would be on oral antiplatelet drugs. This cartoon sort of you're looking at is basically tells about a ruptured plaque and how those platelets gets activated. And even when you do angioplasty or stenting in the setting of STEMI like Dr. Shaw talked about, that is all platelets. Platelets gets distal embolizations, they release a lot of serotonin, vasoconstrictors, and so mechanical intervention is one thing, but it is more important that how you're going to treat it. And then I'm going to talk about something very controversial, and that is platelet function testing. And I don't know how many of you really practice that. I know I did quite a bit at my institute there in the University of Arkansas in our hospital. And we'll talk about that. And I will show you our own data, and I will show you the data around the world. All right, well, that we will begin. My introduction already has been done. So let's, something very simple. We're going to start with, let's examine some pathophysiology here. And I want you to pay attention here. Simple stuff here. This is a model of a platelet, and you know that the most common, anytime you do intervention for acute MI, or for that matter even stable angina, you're going to put on a dual antiplatelet regimen. That means aspirin or one of the other three drugs, which is clopidogrel, or it could be prasugrel or ticagrelor. So let's look at the aspirin first for a second. Aspirin works on COX enzymes, where that is going to convert into thromboxane A2, and thromboxane A2 is converted into thromboxane B. So that's where the aspirin works. And we will talk very briefly about aspirin. That's so important. And then I will talk about the second medication, which is clopidogrel, called Plavix, and I don't know what the name is here, and prasugrel, and the ticagrelor, which is a brand new drug. Aspirin. There are many studies done. Over here, I have indicated many meta-analyses here, but needless to say, the most important take-home message here is any dose between 81 milligram to 325 milligram is good. The odds ratio, as you can see, is clearly much in favor of the benefit. So if you use dose less than 75 milligram, of course, there is not much benefit. Well, why the dose is even important? You've got to ask yourself, well, why not I use 325 in everybody? Why even need to worry about it? Well, the reason for that is, remember, it's all about safety. It's all about safety. If you're getting a benefit, that doesn't mean you want to compromise your safety by bleeding. If you look at this, this is from the CURE study, you clearly will see that if you give a dose average more than 200 milligram, the chances of bleeding is much higher as compared to if you use less than 100 milligram. Therefore, in my practice, first 1 month I will use a full dose of aspirin, but after 1 month, I'm comfortable with baby aspirin, 81 milligram. So one more concept about aspirin, then we'll move on, and that is certain people, the aspirin does not work as effectively, and that's because of some genetic polymorphism. That is very uncommon. But one thing I will tell you, and you should practice on your patients, certain people, majority of our people are also taking non-steroidal anti-inflammatory drugs like Celebrex or ibuprofen or things like that. Remember, those drugs also work in COX receptor. If your patient has taken that medication in the morning, and then after that, 1 hour after that, takes aspirin, well, that aspirin is not going to work, because those receptors are covered by non-steroidal anti-inflammatory drug, and it is not available for the aspirin to work. So therefore, if your patients are taking both drugs, tell them to take aspirin first, and then of course And this is the one way of saying, well, you know, if you do the platelet function testing, your aspirin may not be working because just is not taken at the right timing. This basically is the only data we have to show whether aspirin responds well or not is from the HOPE trial. And over in this trial, clearly if you see that thromboxane B, the levels are very high, that means aspirin obviously did not work, and there was a, they could not convert COX-1 to thromboxane A and thromboxane A to thromboxane B, and obviously that was seen in the urine, and that's indirect evidence that aspirin was not as effective. So let's explore our second possibility, other set. So about the other regimen we're going to use, clopidogrel, prasugrel, or ticagrelor. I will be very brief on these because I want to really delve some time on the platelet function testing. There is quite a bit variable response. All of you who are sitting here, if I believe 30 to 40% of Indian will not have an adequate response to clopidogrel. That's not, it's just the way our genetics are. It is about 30% in Caucasian, about 35% blacks, and much higher incidence in Indians, and much higher incidence in Chinese. When your patient is taking aspirin and clopidogrel, you also should be careful what other drugs you will give. For example, if your patient is taking omeprazole for GI upsets, you've got to be mindful, it's going to be working on that CYP2C19 enzyme, and that omeprazole may not work as effectively. This has been very well shown in a study, it's a Denver VA study, where they looked at that people who are on PPIs, which is omeprazole, as well as on clopidogrel, they did very poorly as compared to the people who are just taking clopidogrel. And there is a logic behind that, and we'll discuss that very briefly. The logic is this, like I told you, in my audience, if we do all genetic testing on each one of those, about 40% of you will have one of the functioning of CYP2C19, which is just not working as effectively. So therefore, if everybody is given Plavix, about 35 to 40% people just not going to respond it. That's the way our genetics works. And that's clearly shown over here. For example, if your patient is taking clopidogrel, 85% is lost right away in the GI system. The 15% what is left is going to go to the liver. It has to undergo through 2 oxidation steps and get a final product which will work, which is called active metabolite, which will work on your platelet receptors. And so if you use any drug, for example PPI, that's going to compete with this enzyme, CYP2C19, and that's why your clopidogrel may not work very effectively. So it is very important to keep in mind that there could be 30% of the people who may not respond as effectively, and there are 3% of the people who may not respond at all to this drug. And of course there are other drugs available to be used. This was a recent trial presented at the AHA, which basically says the same thing, that CYP2C19 reduced functioning allele, the Plavix or the clopidogrel just does not work as effectively. This was shown in this trial. They really pushed the envelope. What they did was, they gave it on day 1, the patient was on 75 milligram of clopidogrel, then they did the platelet function testing, then they gave 150 next week, then they gave 225, then they gave 300. So the question was, each week they're trying to figure out what happens if these people are having CYP2C19, that genetic variation. So some of you who are carriers of CYP2C19 and are heterozygous, it will, even if we push the clopidogrel up to 300 milligram, it will not work. Just because, like I told you one mechanistic slide, because if the CYP2C19 is not available, your primary drug will not be converted into active metabolite, therefore it will not go and work on the ADP receptor. There are some new drugs available, of course now, and I would be very brief on that. One is the prasugrel. Prasugrel has been tested in a large trial of Triton-Timmy 38. There was 13,000 subjects, and it was clearly shown that it is much better. There is 19% relative risk reductions of endpoints, particularly acute MIs. And there is recently another drug which is approved, which is ticagrelor, and that is also have been shown. It was tested in a large trial called Platelet and clearly showed a morbidity and mortality benefit. The reason I'm showing these two drugs is because they are not subjective. They are not affected by CYP2C19. For example, those of you here in the crowd has a CYP2C9 hypofunctioning alleles. If I use these drugs, prasugrel or ticagrelor, there is no problem. In other words, if this was a drug used all the time, platelet function testing will have no role. All right. Let me be a little, I know I probably don't have much time, but we'll go through the right very quickly. I generally make this very provocative statement, and you can read it. Do we manage blood pressure without watching the blood pressure? No, we don't do that. Do we manage diabetes without looking at the glucose? No, we don't do that. Do we manage warfarin without looking at patient's INR? No, we don't do that. So why we use antiplatelet medication all the time without even knowing does it work it or not? This is a provocative hypothesis, and we have looked at that. There are many trials. I will share a few. For example, look at this trial called ADAPT. It was a large trial of 8,500 patients, and what they looked at was platelet function testing. And there's a concept of PRU. If some of you who do platelet function testing, you will know what PRU is. It is a platelet reactivity unit. If your platelet reactivity units is more than 208, that means your drugs are not working as effectively it should work. In this large trial, it clearly showed that if your platelet reactivity was very high, like PRU unit is more than 208, they clearly had a higher risk of stent thrombosis. In other words, saying the same thing, that your antiplatelet regimen was not working. All right. Now, you can have a cutoff of either 2008 or 2030. This is a platelet reactivity unit. And as you will see clearly, with this cutoff, and it's a significant that defines our probable stent thrombosis at 30 days. Now, even based on many trials, the European guidelines came up with this. They said, okay, well, in acute MI or STEMI, we probably need to use prasugrel, ticagrelor as a primary drug. That is not a position of the US guidelines. Well, at this time, what I will do is I will mention a few more things. We recently did a platelet function testing in our own institute. There was about 533 patients, and the question was, all these all-comers coming to the emergency room, is this medication working? They're coming with a chest pain. I have implanted a stents in them, and I want to know, the patient is on aspirin and Plavix. I want to know whether this drug is working or not. So we did a platelet function testing. And we were amazed to know that almost 40 to 50% people, it was not as effective. And there was 4 risk factors which really stood out. Number 1, the people who were diabetic, it wasn't very effective. Actually, the black race turned out to be one of the very significant factor. Obviously, in our study, there was Indians were very few, so can't make any comment on that. It was also less effective in women. So, with the take-home message of this presentation is, number 1, in your acute MI interventions, be careful your dual antiplatelet regimen. You always should use aspirin. Be careful about your non-compliance issues. Number 2, if you're using clopidogrel, always understand there's 30 to 40% of the people it may not be working. Maybe you need to double dose, or maybe you need to use the alternative medications. And clearly there's a role of, it's controversial, but there's an emerging role of platelet function testing. It is coming up. Well, thank you at this time, and appreciate your attention.
Thank you, Dr. Sharma, for the nice presentation. So coming to the end of this session, we had 4 presentations in this session. First was on PCI in ACS. Regarding PCI should be done in all ACS patients. Last one there was ESC, European Society of Cardiology conference. At that conference, newer guidelines were presented for acute MI, and new definitions of MI were evolved. And according to these guidelines also, every patient of ACS should get an ECG within 10 minutes, thrombolysis within 30 minutes, PCI within 60 minutes, or if transfer is required, to be done in 90 to 120 minutes. And PCI should be referred in all patients. And second presentation was echo in cardiac emergencies. So rightfully said that echo is very important to diagnose or rule out pulmonary embolism, acute MI, regional wall motion abnormalities, acute MR, pericardial effusion, tamponade, cardiac rupture, ARDS, that is to differentiate cardiogenic and non-cardiogenic pulmonary edema. Takasabu cardiomyopathy is one more, stress-induced cardiomyopathy, reversible cardiomyopathy. Many patients come in emergency undiagnosed. And in India also, we have some undiagnosed patients who present in emergency with heart failure. So many patients of mitral stenosis, cardiomyopathy, aortic stenosis, and undiagnosed shock. Echo is really very important for diagnosis or rule out these diseases. Next presentation was ischemic MR evaluation, and acute MR has some problems regarding severity. Assessment of severity is not as accurate as it is in chronic MR because LV size is normal, patient is in distress. And it is transient and it is dynamic MR, and it has a very poor prognosis. And coming to the last session was antiplatelet and antiplatelet testing. And we had ticlopidine earlier, then came clopidogrel. Clopidogrel has problems of slow onset and heterogeneity and resistance. And then there was prasugrel. Prasugrel cannot be used in some groups more than 75 years and with cerebrovascular accident patients and in low body weight patients. So we have one more alternative, ticagrelor. Ticagrelor is launched last week only. I got samples of ticagrelor for evaluation last week only. So we have newer antiplatelet drugs, and platelet testing has been done in some studies, and it was assessed that higher doses of antiplatelet is not useful, and platelet testing done in some studies, some are negative studies, some are moderately positive. So now session is open for discussion and questions if any.
There is one question asked to me from the audience. He is Dr. YJ Dave, a pediatrician from Porbandar. The question is, when there is no setup for emergency transport, in bracket that is helicopter for emergency PCI query. I think I had already showed in my slide, algorithm that if the patient has come to a non-PCI capable center, then you have to thrombolize the patient if you cannot shift the patient to a PCI center by these modalities. So that is very well answered, Second question that he asked in bracket again, I think the cardiologist and cardiac intensivist or interventionist should sponsor the setup. I think that's not true, It's not an individual who can do these things, It's a teamwork, and it is the whole healthcare provider system which can stimulate this system for effective treatment of patients who land up with ST elevated MI in at centers where there is no PCI capabilities, So it's not an individual who can sponsor or something, that question doesn't arise, It's a multi-task effort by government, medical health providers, doctors, cardiac society, etc. It just cannot be done by individuals. Thank you. I hope I have answered your query.
Helicopter is not essential for transport. Advanced cardiac life support ambulance is required, and one physician is required to be transported, to be accompanying the patients. And now there is a pharmaco-invasive therapy. During transport, thrombolysis with tenecteplase can be given. It is 10 minutes bolus injection, and then PCI can be done after tenecteplase injection.
Sir, one more question. As a routine investigation after myocardial infarction, on the 4th day or 3rd day, if you do an angio, it shows an acute total occlusion. So what should we do, and we should let it go into a CTO or should we intervene?
Your question is that if you do a ST elevated MI angio on the 3rd or 4th day,
yes sir, it has totally
on a
resolved.
diagnostic coronary angio which is totally occluded, the answer is that you should not do anything to those patients. The court trial has clearly shown and very well dissected, that there is no benefit to a patient who comes after 3 days if he has a asymptomatic 100% occluded artery, whether you have thrombolized or not thrombolized that patient. So there is no question of doing any intervention. In fact, it is class 3B recommendation. That means you may harm the patient by opening that artery.
So we have to leave it to go into a CTO.
Yeah, you have to leave it for at least 1 month and then assess by other modalities whether he has a viable myocardium and what is the amount of myocardium at geopard A, and then you can take him up for intervention or surgical.
Thank you.
If patient is stable and asymptomatic, nothing is to be done. If patient has cardiogenic shock or ischemia or evidence of heart failure or arrhythmias, then intervention can be done. But in a stable patient, nothing is to be done.
So a timeline of 1 month is there, sir? After 1 month?
After 1 month, then you have to assess by the modality whether patient has got ischemia which is reproducible, what is the amount of myocardium at jeopardy, whether it is retrievable or not, and then you may suggest for interventions.
I make a comment on that. Number one, the OAT trial is very, very old trial. Okay, what Dr. Shah said is absolutely correct. It's a type, it's 3 level, it's a contraindication. But remember, things have changed. Hopefully, we will never wait to do the angiography on 3rd day. I mean, that's too late. Myocardium is. But on the other hand, if that patient is symptomatic, having ischemia, there's collateral well talk, and there's indication for opening occluded vessels. But in acute MI, there should not be any occluded vessel on 3rd day. 3rd day is too late. The myocardium is dead. In the OAT, the sub-analysis of OAT, just to say a few things, people have done revascularization. They think it provides electrical stability.
This question is pertinent to Indian situation because we get number of patients on 3rd day, 4th day of MI.
Another, what Dr. Sharma says, that OAT trial should not be taken that seriously also, See, in OAT trial, all the patients were not LAD occluded, In fact, OAT trial had only 30% of the LAD occlusion. Rest were RCA, circumflex, which is not subtending a very large amount of myocardium, So always, I don't think you can extrapolate those results of OAT trial that you just cannot do, Just cannot. I just want to, because it's not, LAD is different from RCA total occlusion and LAD total occlusion proximal,
It's a beautiful seminar. I'm Dr. Ken Sapara from Philadelphia, USA. And my question is to Dr. Sharma. Excellent presentation. I think this is a very underutilized test, even in USA, platelet function testing. I just had simple 2 questions. What is the specificity and sensitivity of the test? What is the cost factor? And third thing, what we have been doing for last many years in my area is, as you said it correctly, there are certain sub-segment of populations at higher risk for platelet inhibition with the plavics. So what we have been doing for clinically, as you know, insurance industry does not cover a lot of automatic testing. So we have the people who have refractory angina after the acute intervention or recurrence of second event, which may be in form of positive nuclear stress test or recurrence of angina within first 2 months. We automatically switch them to the second line because of insurance industry. In India, I don't know how it is, but it may be a different way of thinking should be implemented. Although Plavix is one of the cheapest drug for people around 50 to 60, which I think a lot of people get intervention, thought process should be changed. Also, I just want to share the data. In my hospital, we have found, because of a lot of people above 75, as doctor said it correctly, we cannot use the second line FEN very quickly. We have been using Brilliant more often, and we have positive results for last 8 months. But it's excellent presentation by all of speakers. Thank you very much.
Thank you much. I don't know whether it was a question or comment, but I will answer one thing. Platelet function testing, even in the United States, 80 or 90% of the cardiologists are not sort of buying it. In other words, they're not doing it. I'm probably the only one in the Midwest area, and it was my interest in platelet function testing. So, but here is the take. Even the ACC/AHA has taken a position. It is not level 3, number 1. It is not class 3, so it's not contraindicated. So number 2, then you look at one trial. There was a Gravitas trial. It didn't really made any difference, but there was problems with that trial. So the take-home message I tell you is, in your patients, acute coronary syndrome. Acute coronary syndrome, if you're going to use aspirin and clopidogrel, you better make sure that your clopidogrel works, because 35% of the patient, if you use it here, it's not going to work. So how do you know which one are those 35%? That's why the European cardiology, they took the position, they took ticagrelor and prasugrel as the first line. That was probably the logic which US hasn't done it. Number 2, if you're going to do a very complex interventions, multiple stents, bifurcation stents, saphenous vein graft stents, you've got to make sure your antiplatelet medication works. For the same reason I made those provocative comments, while you're using for the purpose of antiplatelet drug, you've got to make sure it works.
we have to end this session due to lack of time. We have a message from organizers to move on to the next session. So thank you again to all the speakers for the nice presentation.